Good morning, everybody. At the outset, I would like to thank Kalvit Bhai for giving me this opportunity to interact. And I think one of the best things of having a senior person taking a lecture before you is that he makes things easy, and it is more easier to put the concept because there would be a lot of overlaps. I would be speaking on when to put an IUL, where to put an IUL, which IUL to put, and so. Yeah. So I think there will be a lot of things which I would be borrowing, or rather there will be a lot of overlap which sir has already mentioned. So we can go a little quickly, and if there are any doubts or questions, we can take them. When to put an IUL? So there are a lot of debate, a lot of controversies, a lot of arguments, and almost everybody have their own way of doing things. And so in science, we all know that it is more of an experience that you have. And that is what you do. So less than 1 year of age, I normally tend to not put an IUL, or above 1 year of age, you normally tend to put an IUL, but then it depends. So the second argument would be whether it is unilateral or bilateral, what is the size of the eye, and then there are a lot of people in which, when they were younger, we had not put an IUL, and when they grow up, we put an IUL. So when to put an IUL? Age, if we take age as a criteria, less than 1 year, IUL implantation can be done. Well, it depends on whether your corneal diameter and intersegment parameters are good, whether it is unilateral or not. So the size of eye, I personally think it is very important. I was trained at Arvind, and there we used to, measure corneal diameter for all the cases, all the patients, all the cases, regardless of whatever is the age. There was a column, corneal diameter, and we have to do it. So that is very important. For us, it is a case-to-case based decision. Whenever you are operating in children less than 4 or 5 years of age who do not cooperate for keratometry, handheld autokeratometry is a must if we are planning an IUL. Above 1 year, IUL implantation can be done. I normally do it. Corneal diameter should be measured in all the cases as we say and as we were taught. Auto-K immersion biometry is needed, and under correction has to be kept in mind. We will take it when it comes. Laterality. See, unilateral IUL is a must. But then when we say IUL is a must, we should understand that corneal diameter and entry segment parameters and axial length should be supporting it. We don't want to put an IUL in a small eye where we end up into angle closure glaucoma, or as such also in pediatric patients, secondary glaucomas are very common, and we should be aware that entry segment parameters should be taken into care whenever we are planning to put an IUL. Why we are so forthcoming or willing to put an IUL in a unilateral case is because amblyopia is difficult to counter without IUL. So IUL should not be implanted if the surgeon feels that it will lead to glaucoma or other complications. We should not put an IUL, but otherwise we should try and put an IUL. For bilateral cases, yes, we can wait because we know that the amblyogenic factor is not that bad. Both the eyes are affected. We can leave them aphakic, and we can wait till if the child's age is more than 2 years, then we can implant an IUL. And after 2 years, we can put an IUL. But most important thing again here, as sir has said, we should do a posterior capsular access in almost all cases. I do it till 8 years of age and uncooperative patients. Size of eye, these are what I follow. Less than 10.5 millimeter, no IUL. Less than 9 millimeter, small IUL, which is available. The haptic size is 10.5, but not as a primary case. So I don't put an IUL if the size of the cornea is less than 10.5 millimeters. This 9 millimeter is only for the cases when you have already operated, patient is 5 or 6 years of age, and you are planning a secondary IUL. Then you can put a pediatric IUL or a small size IUL, which is available in PMMA. And axial length, when it is less than 18, together with less than 10.5, age less than 1 year, no IUL. Less than 19 millimeter, age less than 1 year. Bilateral, this is what I follow, so it could be different for different people. So unilateral, we can implant an IUL when it is more than 19. Secondary IUL, once you have already done a bilateral cataract surgery at the age of 1 or 2 years, when we have not put an IUL, we can plan a secondary IUL at the age of 4 to 5 years. Bilateral cases, unilateral after 1 year of age, because we are already fighting with his amblyopia. Again, what is more important is corneal diameter and axial length. So laterality and size, this we have already discussed. Which IUL to put? So sizing is important. You can put a normal adult IUL, you can put pediatric IUL. And then there are customized IOL also, which you can order to the company and get it made. I have a talk afterwards. I'm not taking it into this because it is not the topic. Hydrophobic is preferred over all the materials, whether it is 3-piece or single piece. Undercorrection, we will see. So undercorrections, depending on the age, and again, see, undercorrection is another subject where everybody have their own formulas. These are, I won't be going a lot into those formulas because I think Dr. Kalpit will be taking that. There are two small things which I will be taking. One is to draw the attention to this thing. So normally when we undercorrect on percentages, we tend to undercorrect more in smaller axial lengths because we are undercorrecting on the IOL and not on the axial length. So if the axial length is 21, we undercorrect 4.5. When the power is 22.5, and when we know that this particular patient is going to tend to become more myopic over a period of time, while this patient will not be as myopic or as fast progressing as this would be, but yet we undercorrect more here, less here and more here. So my point here is that we should be undercorrecting more in myopes and less in hypermetropes. And second thing is this, a lot of times, I know there are a lot of people who, all the pediatric surgeons know this, but a lot of times what happens is that when adult ophthalmologists sometimes, when they have IOL power, they have a number in their mind, they would be undercorrecting 4 diopters. And if they have the IOL power, they will undercorrect directly from the IOL power. Sorry, yeah, got it. So you don't have to undercorrect directly from the IOL power. You have to feed it into the machine as the desired refraction. You will be surprised when you do it. You will find out that there will be a difference of almost 1.5 to 2 diopters. And that is what happens when you do it directly and you realize it in post-op refraction that there has been a surprise. You undercorrected 4 and it has only undercorrected by 2.5 or 3 diopters. So that is also very important. When you are undercorrecting, you don't have to directly undercorrect from the IOL power because of the back vertex distance. As you understand that you have to undercorrect on the machine. You have to feed it into machine as desired refraction. This is, I don't think this is very necessary. I will be presenting it as a paper. And so how much to undercorrect? These are different formulas by different people. So there is a rule of 7 where maximum undercorrection is 7. So this is the example. If you have 3 years of age, you undercorrect by 4. Again, see here, I have shown that you are undercorrecting like this, but this you have to feed it into the machine. You don't have to directly undercorrect it. These are undercorrection based on percentages. These are undercorrection based on age and not on axial length. Last, I will be talking along with the video only. So where to put an IOL? As Dr. Sudarshan has already mentioned that it has to be in the bag. Single piece is meant for in the bag. It has been made for in the bag. If you see the box, it is written in the bag IOL implantation. It is meant for in the bag IOL. That is the point which I am drawing home. 3-piece is can be put, as he said, can be put in the bag, can be put in the sulcus, and wherever you want to. So in the bag is most desirable. Optic capture with haptic in the bag, and then optic capture with both the haptics in the sulcus. So this is in the bag. This is haptics in the sulcus and the optic in behind the posterior capsule. And this video shows you the IOL in the bag with the optic capture. So this is the last slide. I will be finishing with this. So I'm showing 2 videos. Here we are doing a posterior capsular rhexis with microrhexis forceps, as sir has shown. And then so we put IOL in the bag and then do posterior capsular rhexis. This is how we were trained. I think one of the most important thing in this particular thing is that in the bag implantation, I personally believe is more important than doing the posterior capsular rhexis. If you don't put IOL in the bag, you will end up with a lot of complications, and most of the complications can be avoided by putting IOL in the bag. Glaucoma, optic capture, PCO, all the things are when you put it in the sulcus. If you put it in the bag, most of the complications are avoided, and even if you are not able to do a good posterior capsular rhexis, you can do it in the next sitting and you are not doing a big harm. But if you don't put it in the bag, then you lose everything. So this is just another video where we are doing vitrectomy, and I tend to, I've started this very recently, so I try to put it in behind. So this is the tug. This has gone. Here it has gone behind the posterior capsule. Now here it has gone behind the posterior capsule, and then now it goes behind the posterior capsule, and then finally from this side. So the optic is behind the posterior capsule, and haptics are in the sulcus, in the bag. I'm sorry. Thank you very much. Thank you.